কত জায়গায় যাবো বলুন দাদা, হাজার সাজ আছে।
So we are starting our clinical meeting on reconstructive urology. I invite Dr. Somannath Mandal sir, HOD National Medical College, who is the convener of the program. I also invite Dr. Malapeda sir, President, Veterinary Society, to come to the dais and to inaugurate the program. And I invite Professor Dr. Dilip Karmakar sir and Dr. Dhananjay Kumar sir to kindly come to the dais. Dhananjay sir, please, to kindly come to the dais and to preside the sessions. Malapeda sir, please come and inaugurate the program, and Suman Mandal sir then take over the program.
Good morning to my teachers and senior faculty and students, dear students. Today in this clinical meeting, our aim is to highlight the experience of institutions about the reconstructive urology. There are various cases regarding the urethroplasty, ureteric reconstruction, and other cases also. I invite all the dignitaries in the dais, Professor Karmakar. May I invite Dr. S. Bajoria. His topic is dorsal BMG.
So our first speaker is Dr. Suresh Bajoria. He is from Kolkata National Medical College and his presentation in female urethroplasty.
Good afternoon, teachers and respected faculty members. I am Dr. Suresh Bajoria from Kolkata National Medical College, and I will be presenting a case series that we have operated in our institute. The case series is on dorsal onlay BMG urethroplasty in females. Coming to an introduction on the topic, female urethral stricture disease is an uncommon pathology, and there is a lack of consensus on the exact definition of the disease. Dilatation has been the mainstay of treatment despite poor long-term efficacy of the said procedure, and adoption of urethroplasty has been very recent, and it has been slower in females, mainly because of the surgical approach, because there is lack of consensus on the exact treatment and regarding concerns for the complications therein. So the aims of our study was, it is a retrospective observational review of the patients who underwent female urethroplasty by the dorsal onlay mucosal graft at the Department of Urology, Kolkata National Medical College, Kolkata. All female patients undergoing urethroplasty between 2021 January and March 23 were reviewed. We operated on 7 patients, and all the patients presented initially with complaint of lower urinary tract symptoms which were not responding to medical management. 4 out of the said 7 patients had to undergo an SPC in view of increased PVRU or retention. 5 patients out of the 7 had previous history of urethral dilatations and recurrent stricture urethra. 2 underwent upfront BMG urethroplasty as per our planning. The patients were followed up at 3-week intervals, 12-week intervals and 24-week intervals post-operatively. The primary outcomes of our study was surgical success, which was defined as no recurrence of stricture, and secondary outcomes, improvement in Qmax, reduction in the PVRU, and whether any incidence of any complications. So the surgical technique, the patient was placed in the lithotomy position, a guide wire was placed under ureteroscopic guidance, and a dorsal suprameatal incision was placed from the 10 to 2 o'clock position, and the urethra was detached from its dorsal attachments. Urethra was incised at the 12 o'clock position, intermittently placing stay sutures till the stricture level and just beyond the stricture level. There was placement of apical sutures for the placement of graft therein. So here is the first picture of the dorsal curvilinear incision, and once the graft was harvested, the apex of the graft with the mucosal surface towards the urethral lumen was first placed after placement of the apical sutures. BMG, as harvested by the assistant surgeon, was first sewn dorsally with 40 PDS sutures, first placing the apical sutures and then placing the intermittent sutures which were placed while incising the stricture. Urethral meatus was thereby approximated to the vaginal and vestibular epithelium over a 14 French silicone catheter, and vaginal pack was kept for a day and dressing done. The catheter was kept in situ for 3 weeks as our institutional protocol. This is the picture showing the suturing of the graft which is taking place, and the final picture of suturing of the urethral meatus to the vestibular and the vaginal epithelium. This is the final picture after suturing the urethral meatus to the vestibular epithelium with the PUC in place. So the mean age of the patients presenting to us was 50.21 years, and etiology was primarily idiopathic, that's around 72% of the cases. 5 out of 7 patients, as said, had previous urethral dilatations with no success. And in our study of 7 patients, the location of the strictures, 2 were distinct, 4 were mid-urethra, and the proximal urethra was 1. The mean Qmax post-operatively was 15.2 ml per second compared to a pre-op mean Qmax of 5.2 ml per second. The mean pre-op PVRU was 150 ml, whereas the post-op PVRU was around 60 to 65 ml. One patient on follow-up required a subsequent urethral dilatation as a secondary procedure due to recurrence of symptoms at 40 weeks of follow-up. None of our patients developed de novo incontinence, either stress or urge, or graft-related complications, uretrovaginal fistula or dyspareunia. This is the uroflowmetry pre-operative of one of our patients. Pre-operative uroflowmetry showing a classical stricture pattern, and post-operative uroflowmetry with a classical bell-shaped pattern with a complete resolution of symptoms. So just a short discussion on the topic. It has low prevalence and it is poorly understood and underdiagnosed. It accounts for approximately 6.8% of the causes of bladder outlet obstruction in females. A study by Sarin and others reported the etiology for female urethral strictures to be idiopathic maximum in around 51% of the cases, which we have supported in our short study. The definition of a female urethral is dubious and is subject to debate. Most series report a urethral caliber less than 14 French as the threshold for female urethral strictures. There are no definite guidelines on how to treat female urethral strictures despite multitude of techniques being published. In general, a trial of urethral dilatation is performed initially. So, in the literature, a variety of surgical techniques have been described. Heineke-Mikulicz meandroplasty for short distal segment strictures, flap urethroplasties, which can be anterior vaginal wall, lateral vaginal wall, or vestibular flaps, and free graft urethroplasty, which can be either dorsal onlay or ventral onlay. The success rates of flap urethroplasty is approximately 91 to 94%. So, but however, no large and well-conducted comparative trials have been performed to evaluate whether one technique is superior to the another. And therefore, the choice of technique is mainly dictated by the treating surgeon's expertise and preference. Coming to a short discussion on the dorsal and the ventral procedures, the dorsal flap procedures are technically more challenging with increased risk of bleeding and damage to the clitoral bodies. However, although ventral procedures are easier to perform, they have a high risk of fistula formation, uretrovaginal fistula, and graft circulations have been seen at an increased rate in ventral procedures. And there is increased risk of SUI in dorsal procedures as compared to ventral procedures. So our experience adds to the growing body of data on dorsal BMG urethroplasty in females. It's a safe and effective management option for female urethral stricture disease. It has acceptable treatment results. The women should be referred to specialized centers for surgical consideration, and repeated urethral dilatation should be avoided. However, large multitude institutional studies are required to prove further reliability. These are my references, and thank you.
Suhas, how have you diagnosed this urethral stricture in your cases?
Sir, in our cases, 5 patients presented with lower urinary tract symptoms, persistent lower urinary tract symptoms, mainly voiding LUTS and partially storage LUTS. So in our follow-up, we had done a uroplometry where 4 out of 5 patients had classical stricture pattern, and most of the patients had developed lesser Qmax. And so 2 patients developed acute retention. When we tried putting an perurethral catheter, it did not go, so we had to do an SPC. Following which we had to, the patient underwent MCU. In our MCU, in our patients, sir, 5 patients did not have a classical MCU pattern, so they were diagnosed on cystoscopic examination. We had to take the patient to OT for a urethral assessment.
So how you can diagnose in cystoscopy the stricture? What sort of scope you will use?
So we use a ureteroscope. In order to first we'll try to put in a guide wire, and if a guide wire goes, we'll try to use a 6 French minimum caliber ureteroscope to see whether there is any patent urethra left or not. Sir.
So another question is whether UTS is required in these cases or not?
Sir, we did not perform UDS as a regular this thing, sir, but chronically obstructed patients, UDS may be indicated if the patient has persistent storage symptoms. But in case of an organically defined pathology, first the pathology should be treated, then only UDS should be done, sir. Otherwise, it will not come conclusive.
But I differ with your answer in a simple because in female cases, if you read both of the books, they have recommended UDS.
Okay.
Even in case of stricture, they have recommended UDS.
Okay.
How much is the prevalence of your DXO in female urethral?
Sir,
In your case,
sir, in our cases, this was a small case. We did not find any BXO cases in our 7 patients. Sir.
how could you know that those cases were not
Sir, clinically there was no evidence of BXO, so that's what we had seen.
How did you exclude the cases that I said not in these cases? How did you exclude? Contraindication. You excluded some of the cases. You excluded. How did you exclude?
Sir,
In these cases, I said not.
sir, clinical appearance we excluded whether BXO was present or not, and on the intraoperative picture also we could note whether
Before operation.
before operation the clinical appearance, sir. Only clinical appearance. And since we were using a buccal.
Totally blocked, cannot do it.
No sir, totally blocked we cannot do it. Our patients, the guide wire was, we were able to pass a guide wire in all the 7 patients, so we were able to do a dorsal BMG easily.
What was the age range?
Sir, age range was 45 to 60 years,
So
sir.
there is menopausal group, postmenopausal group or premenopausal?
Sir, 1 patient was premenopausal, but all the remaining 6 patients were postmenopausal.
We tried with HRT in those patients.
Sir, initially when postmenopausal, we usually give vaginal estrogen ointment to reduce the LUTS. But as I said, none of our patients responded to medical management, so we had to go for further investigations, which helped us in diagnose urethral stricture.
Stenosis, actually this is stenosis anterior urethra.
Sir, 4 patients had stenosis in the mid urethra, 2 patients in the anterior distal part, and 1 patient in the proximal part.
So I think actually assessment could be done by simply if you do the urethral calibrations, whether the meatus is small and actually narrow or not. By just putting the, if you do the urethral calibration, you can assess it.
Yes.
Whether the stricture is in the anterior urethra or not. Number 2, regarding the urodynamic study in these cases, but regarding urodynamic study, we have to put 2 infant bearing tube.
Okay, sir.
So if the urethra is normal, then there is no question of urethral reconstruction surgery.
Right, sir.
But if the total urethra is blocked, then first of all, think about this is due to urethral stenosis, this patient is retention. I don't think there is no developed urodynamic study if it is a urethral stenosis.
Yes, sir. just did a stricturotomy, so routinely we did not send any biopsies. Any redundant portion of the urethral mucosa we did not receive to send as specimens for biopsy. But a dorsal stricturotomy was done where a graft was placed, so we did not get an opportunity to send for biopsies.
Now you would like to get the biopsy anomaly, just to exclude the incidence of EX or any other pathology. Just you say that it is non-specific. Non-specific stricture, you mean in all the cases, or you could have other options. You might get the separate pathology. Isn't that?
Right.
Thank you. So our next presenter is Dr. Indra Prakash Mondal from ITG area. He will present bilateral uretary injury.
Good afternoon, teachers and my fellow colleagues. Today I am going to present a case on bilateral ureteric injury. A 38-year-old female patient was referred to our hospital with complaint of anuria following laparoscopy converted open hysterectomy and bilateral salpingocorectomy. The patient underwent hysterectomy at some outside hospital and was admitted at our hospital on the same day with anuria. USG was done, which revealed bilateral hydronephrosis. On POD1, the drain output was around 700 ml, and investigations, blood infections which was done revealed hemoglobin to be 6.1, total leukocyte count was 9,900, urea was 42 and creatine was 2.4. In view of bilateral hydronephrosis, we suspected there could be a bilateral ureteric injury, so we did bilateral PCN on the patient. Both PCN drained almost 1300 ml per day, and drain output was diminished to about 20 ml per day after PCN placement. Investigations on POD4 revealed hemoglobin to be 8.9 after blood transfusion. Total count was 13,000, urea was 24 and creatine was 1.2. Drain was removed on POD5. This CT scan was done to the patient, and it showed that there was bilateral hydronephrosis, hydroureteronephrosis. And in this film, we can see that there is cutoff at level of both lower ureter on both sides. This is the report of the CT urography. There was moderate left hydroureteronephrosis and diffuse luminal narrowing of distal ureter, delayed persistent nephrogram and reduced excretion from left kidney, mild right hydroureteronephrosis with luminal narrowing in the terminal ureter. We did a nephrostogram on this patient, and it showed that on right side there was complete cutoff at about 3 cm below the sacroiliac joint, and on the left side there was complete cutoff at the level of sacroiliac joint. Management, we did surgery on the patient. We did a right ureteric implantation which was stitched on the right side, and on the left side we did body flap ureteric implantation. Intraoperative findings were right ureteric stricture noted about 3 cm below the common iliac artery bifurcation, and left-sided ureteric stricture noted just below the common iliac artery bifurcation. Both ureters dilated above the strictures part. A lower midline incision with extraperitoneal approach was used. Ureters were dissected on both sides and cut above the strictures part. Right ureteric implantation was done with modified Lee-Gregoire technique with swath stitch done over a 5x26 DG stent. On the left side, body flap was treated and tubularized over a 12-inch Foley's catheter and anastomosed with the left-sided ureter over 5x26 DG stent. This image shows the creation of the short segment body flap over a 12-inch Foley's catheter, and this image shows the anastomosis between the body flap and the proximal ureter. Postoperative recovery was uneventful. After 3 weeks, we did a nephrostogram, and it confirmed good healing on both sides. So PCN were removed on both sides. 6 weeks later, bilateral DG stents were removed and RGP was done. Findings were normal on right side, so we removed the DG stent, and on the left side there was mild hydroureteronephrosis, but no contrast holdup was present. But still we kept a long-dural DG stent on the left side, owing to presence of some blebs and irregular mucosa around the left uretrovesical anastomotic site, just to be on the safer side. Thank you.
Hello.
excellent presentation.
Thank you, sir.
Actually, you did exact right treatment. You did a PCNL followed by this drain, and after how many days you operate?
Sir, the OT was done after almost 6 months.
Why so much of delay?
Sir, because
That's because actually
after stabilizing patient,
for 6 months you are keeping this nephrostomy tube.
yes, sir.
Whenever there is the immediate there is injury you need a PCM, and there was no such much of information edema. Right, after the PCM, you can do easily this Swasich and Warifla easily. He did Swasich actually after operation, but if the patient comes up for a long, after 5 days or 6 days, 1 week back, 1 month back, in those cases it is best to wait for not 6 months actually. Cycle injury, urinary injury can be repaired within 6 weeks or actually when you were in the, I was in the department, a patient came from Siliguri, they were bilateral injury. Jan surgeon did ureterostomy and peritoneous ureterostomy. So here we actually did ultimately we did the same thing. This was it along with polycline. It's a good presentation. Very good.
Thank you, sir.
Right. So you have done that body in the right side, no?
Body on the left side, sir.
And right side?
Swasich and urinary implantation on the right side.
Right side. So why not both? Why not Swasich on both sides?
Sir, on the left side we first did the Swasich, but still there was a gap, and we saw that there was if we just reimplanted the uterus, there will be tension, and so we just created a body flap and did the anastomosis.
That's my question. What is the maneuver you should have taken to avoid this body flap? Is there any maneuver, anything you should have taken?
Sir,
Or you have already done that. May not be successful, but have you done that? Some artery.
sir, we could have so the supraphysical pedicle could have been lighted on the left side, but sir, we kept the supraphysical pedicle intact because if on the right side in future there may be a need for lesion of body flap, so we preserve the supraphysical pedicle on the right side.
Sorry, I might have put some exact questions. Maybe I'm wrong. After how many days after this initial gynecological surgery the patient presented to you?
Sir, on the same day.
Same day, same or 1 or 2 days later?
The same day.
So in that case, my question is, you see, because I have got some experiences of tackling such cases. One case I remember, bilateral ureteric injury in Somunath Pandit Hospital done by one gynecologist. I'm not going to name. Some of these people who are present, they are known very well. And the patient, on his first case, this patient had entire urine drain into the peritoneal cavity. Her condition was deteriorating. On the third or fourth day, the gynecologist opened again. And she tried to do something, but anyway, it didn't yield any results. The patient's condition again was deteriorating. So these people, in fact, one of my friend, Pradut, he was there in Somunath Pandit Hospital. I was in PG, contacted me, went there. And around the 10th day or so, in fact, I explored. Yeah, I know there may be some criticisms, but still I am telling you, in the same operation I did bilateral primary ureterostomy. There are a lot of stitches, so remove these stitches, excise the friable fragments, and after mobilization, the primary anastomosis with the stent could be done. Patient's recovery was absolutely uneventful. This is one case. I can even mention the name of the gynecologist, you can contact him. This was a remarkable achievement. Second, another case, same, this patient came with ureteric injury after vaginal hysterectomy and so. And thereafter the patient presented after about about, yes, as far as I remember, maybe 16, 17 days or so, within 3 weeks time. The left side, and in all these cases, when the patient presents later on, you must do this RGP in order to locate the exact location where the ureteric injury has been, and so that you can plan also. In both your cases, the ureteric injuries were below the pelvic rim, if I remember, 1 3 centimeter, other below the coronary arteries. In those cases, your plan should be to primarily re-implantation, it is possible, because this much of distance does not need body or anything of that sort. At best, you may use sausage. So, retrograde apailogram is indicated in order to find out. At the same time, definitely some of these, whether it is partial or it is complete, ureteric injury. If it is partial, you can try passing a catheter, guide wire, if it presses very hard, the same day or day after 1 day like that. If it is partial, you may try passing a guide wire if it is possible and stenty, and may wait. Simple thing. And if the injury is complete, there is separation of the ureters. This at the same time, because of after some time, the upper ureter the ureteric end will get closed. There will be some hydronephrosis, and this lower ureter can be visualized by RGP, the distance, and then accordingly you can plan. And in most of these cases, for second case after within 3 weeks, I am telling you, the left side ureter was stitched almost very, very close to the, very, very close to the ideal vessels, the external alien vessels, and there was a lot of edema. I don't know, and maybe one of our students at that time, now consultant, maybe it was me in the theater. It was done in Gamma Century, nursing home, I remember. And at that time, it was very painstaking dissection. We could cut all the stitches, and it was really, some people may say, why you have done it? It is not immediate after 2 weeks, but still, it was a drastic, effort, but an unnecessarily heroic effort, I might say. But dissected all the cuts, I cut all the stitches without injuring this vessels vein particularly, and there was every possibility injuring, but still it took a lot of time. And after that, again I excised these 2 ends, tribal ends, mobilized, and did the primary anastomosis, and recovery was excellent. So before you go for all these, major operations, first thing first, you identify if it is partial or complete, how far away from the ureterovesical junction it is, so RGP, and then plan accordingly. And the first thing, partial, if it is, try to pass a catheter, guide wire, and then you will double just wait. So this is what I wanted to
The
do.
same thing actually, with Professor Chakraborty in our institute, there is same case, after Caesar sections, they call us on the next day. The patient is completely anemic, so we can remember, and we went there, the ultrasound shows bilateral hydronephrosis. We tried to put a ureteric catheter on both sides, we could not find it, we explored it, and we instantly did the ureteric intervention. Actually what happened at that time, there is no edema, you can easily identify the ureteric, easily mobilize it, and you can do simply next day morning, actually they did it, the evening. It was one contributor, because it's one thing, just bring about what we do. When I did the same thing as when I was in Mapura, they called me in the morning, these things happen. Instantly knew that there is no edema,
What could be the problems of leaving a bilateral nephrostomy for a long period of time?
It causes more fibrosis actually. People are saying,
What are the problems of leaving a bilateral nephrostomy for a long period of time? In this case.
Sir, there is a chance of pyelonephrosis or pyelonephritis if you keep the stain for a long time. So also decreased.
That is why you have heard of something called bladder cycling in people with chronic
Yes, sir.
renal failure
Yes, sir.
prior to transplant.
Yes, sir.
So these are the problems. Third thing is the PCN can get blocked from time to time and there will be intermittent leakage through the fistula. And as sir said, there will be more fibrosis. So these are three. What will you do? Suppose the bladder capacity was small. Here you were lucky that the bladder capacity was good. Suppose the bladder capacity was only 250 ml. Then what you would have been your surgical options with the same scenario?
Sir, there are some other options which you can explore. Like we could combine the sausage and renal decences. Then there will be we could gain addition in the 4 to 5 cm. Or else, sir, we could have done a transuretral hysterostomy. Or and
bladder capacity is small.
Increase the bladder capacity.
Bladder capacity is small. What will you do?
Okay, you have rightly said. One is you can do PUU and then do a Buhari on one side.
Yes, sir.
Okay, what else? Any other options available?
Sir, we could do a ileal transposition, sir.
And number another thing also. Can you go back to your CT scan?
If the bladder capacity is small, you have to increase the capacity. How will you increase the capacity?
Sir, we
What are the
can.
methods to increase the bladder capacity? What are the different methods to increase the bladder capacity?
Sir, bladder recycling has.
Suppose it is 150.
Yes, sir.
What are the different methods to increase the bladder capacity? What will you tell me?
Sir, as sir said, bladder recycling can be done, and then sir,
Okay,
and operating, sir, we can use intestinal segments and increase the bladder
What is the
capacity.
name of your test? Ileocystoplasty.
Ileocystoplasty.
What is the other option? One is the ileocystoplasty or cholecystoplasty. What are the other options to increase the bladder capacity? No, segments. Other than this, using the segments, what are the other options? It's all written in the calendar.
These are the questions asked during your exam.
Any of the PGTs can answer it. Rest of PGT, please answer. Hypertension is.
No, open procedure. He has opened. He has opened. He tried to increase the bladder capacity. One is you can use the segment of stomach, you can use the segment of small intestine, colon, whatever may be. Other than this,
Get to the myotomy.
that is the myotomy.
वही लिखा है कैमरे में तो
Wait, next.
वो तो मोटे लिखा है.
Thank you, sir, for the discussion regarding.
I wanted you to show the CT scan once again. And the CT scan was done after the PCN. After the PCN. So can you just focus which side? Where is the PCN tube? And it is still dilated, the
I
ureters.
think it before the
This is
before the
Say that.
Okay, sir, the next presenter is Dr. Shahbaz Ahmed from Medical College, Kolkata. He will be presenting his management of a case of double color.
Good afternoon, teachers and colleagues. My case presentation is on a case of management of double phallus. Now, a 14-year-old boy came to our OPD with chief complaints of pain and swelling over his left scrotum associated with fever for the last 6 days. There is a history of surgery in early infancy in 2013. Now, on physical examination, there was a left scrotal abscess present and the patient had double phallus. The right phallus was of normal size, placed laterally, and the external urethral meatus of the right phallus was in normal position. The left phallus was smaller with epistatic meatus located at the midline. His left scrotum is well developed with normal testis, the right scrotum was underdeveloped and the right testis was located in the right inguinal region. On examination, we also found that the patient had imperforate anus for which colostomy was made at early infancy. Now, this is the photo. The right phallus, as we can see, is normal in it was of normal length, and the left phallus was in smaller length and it was epispadiac. And the scrotum on the right side was also underdeveloped with the right testis present in the inguinal region. We did certain investigations. An ultrasound was done which confirmed that there were 2 bladder cavities with an incomplete septum in between communicating the 2 cavities. The 2 phalluses both had 2 corpora cavernosa each. So this is a case of complete diaphagia. The right undescended testis was identified in the right inguinal region on ultrasound as well. Now an RGO and MCU was done. As you can see here, that there were 2 bladder cavities and 2 urethra. The right bladder cavity was of normal caliber, but it also had a diverticulum. The left bladder cavity was much smaller in capacity, and there was a spatulous bladder neck on the left side. The RGO of the right phallus appears normal. Now, X-ray of the axial skeleton shows severe kyphoscoliosis with cubic diastasis. A CECT of the whole abdomen was done. It showed the presence of a normal left kidney with absent right kidney. This is the urogram showing a single kidney, single ureter with 2 bladder cavities communicating with each other. Now we did flexible cystoscopy under anesthesia for the patient. This is the picture of the right bladder cavity where we can see an ureteric orifice. This was probably the left ureter that was inserted into the right bladder cavity. We also found a left underdeveloped bladder neck with separate bladder cavities with a communication in between. A single ureteric orifice was seen in the right larger bladder cavity. This is the left urethroscopy where you can see the veru and a small bladder opening. On entering the left bladder cavity, we can see that there is a communication with the right bladder cavity, and this was the incomplete septum. We managed the patient with emergent drainage of the scrotal abscess and control of the septic features with antibiotics. After consultation with other disciplines like pediatric surgery, plastic surgery and psychiatric department, we have planned for reconstructive surgery after the patient attains adulthood. Thank you, sir.
What sort of reconstruction you might contemplate or you have in your mind? Suppose you are asked to build a patient.
So the primary goal of is to preserve the erectile and ejaculatory function, preserve the continence and cosmetic appearance of the patient. So looking at this, the RGO-MCU, so I would like to do the total penectomy of the left urethra, which was epispadiac and incontinent, the excision of the left bladder, and the right bladder had a diverticulum, so I would like to excise the right bladder diverticulum as well. And
Anyway, this is a very interesting case and worth reporting, you must. I have got a beautiful picture of fully
so
developed.
it is very rare.
Another, yes, okay. In fact, the left part of the, if the right bladder is of adequate capacity,
Yes.
and if it does not drain any ureter or anything like that, so you can just chop that off and close it. Or you can make these both the bladders sit together by just dividing the area.
Yes, sir.
I want to say something.
Sir,
Double class, I think that you have showed us
No.
a picture of double class.
Yes.
Years back.
And one thing, one I would like to mention that there is the hindguard duplication syndrome, part of. And there could be duplication of anorectum. Is it where or it was absent?
So there was no duplication of the GIT surrounds.
Yes, it was absent.
It was not, there was no duplication of any colon or rectum.
Okay. And another point is the bladder, in spite of one bladder is small, another is adequate. In spite of that, I will prefer cystoplasty, preserving the continent urethra and excising the penis, which is epispadiac and incontinent. That would be better treatment. Okay.
This is a very interesting case. That was I gave this case. It's not as simple that I operate with the epispadiac because patient wants to procreate. So the semen is coming from that epispadiac meatus. He has not mentioned it. But we have examined it.
The right side.
No, not on the right side, on left side. That the small phallus. From there, you can see the veru there, and also you can show that. So it's a very interesting case. I cannot simply chop off the left side because
Yes.
You have shown the left side is well, on the right side.
on the right side there is no veru. On the right side there is no veru actually. Sphincter control, right side is okay. Okay, right side okay. So the thing is that I do not know where there is insertion of the epididymis.
Yes.
Which side? So that is the
Yes,
problem.
that is one.
There is a very valid point. We have to preserve the epididymis for the semen secretion. So it is inserted on the left side. There is small phallus. There is epispadias phallus. So my plan is to keep the left side or the right side.
No, no, one thing. In this situation, yes, continuous is the
Right side.
In this situation, you can anastomose the posterior urethra with the index veins, that is on the
Right side.
adequate veins. That portion is sufficient for ejaculation and for insemination. And another point, that is the chopping of bladder is not desirable, as the bladder capacity will not be adequate after chopping.
We don't have to chop the butter because butter is communicating.
But you can anastomose posterior to posterior side of the opposite patient, and cosmetically you can excise the penis.
So you are saying that we should anastomose the left penis with right penis?
Not penis.
Only urethra.
In the duplication, sometimes we get a duplication of urethra. That time we do urethroplasty to make a single urethra, orthotopic urethra.
You can solve the urethra problem by this, but how it should procure? Because procreate. Because how semen will come?
Semen will come through the normal side. Following anastomosis.
Have you done the RTO both on?
Another thing. Yes, Dr. Sunil, this diastasis.
One kidney, one testis.
This is the left side.
The urethra is quite separated from the both between the color. Is it possible to anastomose the posterior urethra?
So it is very difficult to anastomose the two phallus, sir. Very difficult to.
Not the phallus, urethra, I think posterior urethra.
Left side. Oh, I think so because semen is coming from the left side. I don't know why the urethra is open, but semen is coming from the left side. We have seen that.
Now, I think during operation, one thing that will help, that is the diastasis.
Yes.
During dissection, you need not to go for pupectomy or something like that. At the same time, the urethra, it is most likely it will be closer, not that, it should not be that wide apart. Both the posterior urethra.
What does the patient want?
Patient want that semen procreation. You want to live a long
It is
life.
not coming from the normal urethra.
You want incontinence. You want to procreate.
Patient he is continent.
No, sir. He is not continent. Because it is coming from the episode and gators also. It is coming from both sides.
No. On the other side, he is continent.
Other side is continent.
Can I suggest something?
Yes, sir.
For procreation, you can use any of the insemination methods and let him use the urethra for
So the thing is that if we chop off the left side, what will happen to the epididymis? It will get blocked, na? There is another question. You have to think it is a very complicated case. Not
complicated.
কি বলছো বলো? না তুমি বুঝতে পারছো না। আমি বলছি যে আমি যদি লেফট সাইড পেনিসকে উড়িয়ে দিই তাহলে এপিডিডিমিসে কি হবে? ইজাকুলেটারটা কি হবে?
তোমার কিছু তো ইউরেথ্রাল হসপিটাল হয়ে যাবে।
In that case, you have to fix the opposite of the patient as also psychiatric vasectomy. What will happen next if you chop off the penis, which is normal, or the epididymis, and also you will say that semen is stolen from the left side, you get the consent of the patient to operation.
That's the way I voted for that.
You understand? That you have to go for other for fertility purpose. Very difficult job.
Access formation is there, total access is there.
Anastomose urethra.
What I was suggesting, imagine, I'm just asking, imagine because of this diastasis, so you can directly go to the site, bladder neck region, and both the bladders as well as the urethra, the phallus there, and without disturbing the right side march. Our purpose will be to isolate the portion of the urethra, posterior urethra, where the epididymis is coming and joining. And whether if you can dissect that part of the urethra beyond the opening of the epididymis also. If you find adequate urethral length, then you can take this urethra and go for this urethrostomy or anastomoscopy.
Sir, both the urethra
Is it possible?
what I said. You can see.
Urethra has got some length because otherwise you see he could not have passed the semen through this meatus, this on the left side. It has got some length. It may be narrow, but it has got some length. Our idea is even you may use the help of a operative microscope.
Sir, Vera sir, have you seen the case, sir?
Only incontinence if you join the urethra.
No, close the neck of that portion.
That part is not, that part is incontinence.
That neck should be closed.
Procreation is.
That will be risky operation.
No,
You have to go to bladder neck.
Yes.
You have to close it.
You have to keep the posterior urethra.
Simple thing is that you take help of the assisted reproductive technique and you think for the continence and legs. I think. Why? What you think is the simplest way. Keep the erection, keep the continence, take the help of the assisted reproductive technique.
Next is Dr. Rahul Rai from NRS. He will be talking on GT urethroplasty in distal penile hyperplasia.
Good afternoon, my respected teachers. Myself, Dr. Rahul Roy from NRS Medical College. Today, my topic of presentation is grafted regularized incised plate urethroplasty using fiducial skin graft in distal penile hypospadias. Let's start with history. It was 1994 when Warren Snodgrass first demonstrated regularized incised plate urethroplasty in distal penile hypospadias, also known as classical tip or C-tip. Later in 1995, Duckett and Baskin first used buccal mucosal graft for salvage reconstruction in distal penile hypospadias, and they used it as ventral only. Then in 1999, Malone and Hayes, they used the same BMG, but it was dorsal inlay for same salvage reconstruction of distal penile hypospadias. Then in 2000, Colon et al. They started using inner fiducial free graft for hypospadias repair, and it was dorsal inlay. We have used this technique of using inner fiducial free graft dorsal inlay technique, also known as grafted tip or G-tip, in our cases. It is a series of 5 cases of primary distal penile hypospadias operated between January 22 to September 23. Among them, 3 were pediatric cases and 2 were young adult patients, and redo cases and cases with penile body more than 30 degrees were excluded. Regarding preoperative preparation, we advise testosterone gel 1% for local application for 6 months before the surgery in pediatric cases. Coming to operative details, all cases were done under general anesthesia with caudal block or spinal anesthesia. After preparing genitalia and draping, traction suture was applied to the summit of the glands using 3-0 silk suture. Then infant feeding tube was passed into the hypospadias meatus. Size varies as per the age of the patient, ranging from 6 to 8 French. Then circumferential incision was made below the corona, and then degloving of the penile skin done. The presence of body was assessed and U-shaped skin incision made surrounding the meatus with 2 paramedian incisions between the glans and the urethral plate. After that, dissection of the glandular wings was made from underlying corpora cavernosa to the urethral plate. Then urethral plate was incised deeply, extending from the hypospadias opening to the end of the urethral plate down to the underlying corpora cavernosa. Then the length and width of the graft determined by the length and width of the incised urethral plate using the ureteral catheter. And free fiducial skin graft was harvested from the dorsal aspect. Then it was defatted and sutured to the edges and floor of the incised urethral plate using 6-0 BDS suture. Then the graft was fenestrated using 3 cm syringe needle. Then tubularization of the urethral plate done over all silicone catheter of appropriate size ranging from 6 to 12 French according to the age of the patient and width of the incised urethral plate. Then spongioplasty was done, few interrupted stitches followed by granuloplasty. Then skin closure was done using Beer's flaps after double breasting of the neo-urethral suture line by Dato's pedicle flaps and compression dressing was applied. Regarding postoperative care and follow-up, parurethral catheter was removed after 10 days, dressing was opened after 5 days, moxifloxacin drop and hydrogyl ointment was applied to the wound, antibiotics continued until the parurethral catheter was removed. Follow-up protocol was at 2 weeks and first month, third month and 6 months. If early postoperative urethroperitoneous fistula, metal diameter of appropriate size with 2% lignocaine gel daily for 1 month was advised. Results: mean age was 8.8 years. In all cases, CODI was corrected after penile skin degloving and incising urethral plate. No cases of wound infection, skin sloughing and fever was reported. 3 patients developed leakage of urine from suture line at coronal region after removal of parurethral catheter. In 2 cases, it was stopped spontaneously after 2 weeks of metal dilatation. Probably it was due to sutural separation. But in 1 case, there was persistent urethroperitoneous fistula even after metal dilatation and needling was needed for this case. Follow-up at 3 months, all of them had straight urinary stream, straight erection and all of them had vertical slit meatus. Then coming to discussion, CT is the more commonly performed procedure for distal penile hypospadias with overall complication rate of 10.8%, mean fistula rate of 5.7%, rate of meatal stenosis 4.7% and dehiscence rate of 1.3%. Now the question is why? The possible explanation reported in literature is that there is re-epithelialization of the incised urethral plate which starts on postoperative day 2 and gets completed by postoperative day 5. But in cases of narrow urethral plate, shallow urethral groove and small glands, there is formation of granulation tissue at the urethral plate incision site and there is differentiation of fibroblast to myofibroblast causing wound contraction until the surface is covered by urothelium. Next, coming to the technique of ventral only graft. The major disadvantages are there is high failure rate up to 30% resulting from deficient ventral neovascular supply and scarred penile shaft skin in V2 cases, and there is more risk of urethral diverticulum resulting from deficient ventral tissue support. Now coming to our technique GT. Here the main advantages are it preserves urethral plate, increases the surface area of healthy urothelium, it does not leave the neo-urethra with a large denuded surface allowing for re-epithelialization or possible scar formation. Also, the take-up rate of the graft is good because there is extensive vascular sinuses beneath the urethral plate, and this technique results in vertical slit-like neometas at gland tip without risk of meatal stenosis. And this deep incision in the urethral plate corrects the residual body also, and there is minimal tension on the neo-urethral suture line, and there is minimal risk of urethral diverticulum because spongioplasty gives good tissue support to the new urethra. Also, there is no added morbidity like taking buccal mucosal graft, and it takes less operative time than the buccal mucosal graft. This is one article recently published in the African Journal of Urology by Ahmed et al. They compared this C-tip technique and G-tip technique, and they also observed that the success rate of G-tip technique is 90.7% and success rate of C-tip technique is 90.5%, and they have observed that the incidence of fistula and meatal stenosis is much lower in the G-tip group. Now we have done only 5 cases and more cases to be done to conclude our results. Thank you so much.
Open for discussion and question. What is the age of your patient?
minimum age was 2 months and maximum age was 18 years.
18 years, no?
Yes, sir.
So have you taken the skin biopsy because you are putting a skin there, no?
No, sir.
No, how do you know there is no BXO in that skin?
Sir, clinically, sir, it was appearance, there is no BXO changes on the PPUs, sir. And, but sir, we did not take any biopsies. So we cannot confidently rule out BXO, sir.
Have you done a study between buccal mucus and this sugar diminution?
So sir, till now, sir, we did not.
What would be the study? What would be the study?
Regarding one thing,
Because
you wrote in the history, you have not mentioned the renowned Indian doctors.
Asopa, sir. Dr. Asopa.
Whenever you are writing the history, hypospadias surgery also by the death name.
Comment from regarding the skin grafting and buccal mucus, take up rate.
I have got bad experience.
I think skin grafting is, I am not
Actually, explain. Why there is a difference in BMG and your previous case? How can you explain?
Sir, BMG, the initial, we have used BMG previously in uretroplasty, sir.
Here, so there is less complication rate compared to BMG.
Sir, less complication rate compared to, sir, classical teeth. This type is Snodgrass. They are Snodgrass, does not use any graft. He only incises the urethral grade. But we are using one fiducial skin graft in that incised grade defect.
Your is not graft actually.
Yes, sir. It's not graft.
How much body was there in those cases? The age range was 8 months to 18 months.
Yes, sir.
How much
18 years, sir.
18 years.
Yes, sir.
Whole 18 months in the
You have followed up your patients and all the grafts have been taken.
Yes, sir. Skin graft has been taken, sir. There is no issue. The issue is only one case. Patient developed urethral fistula.
That is
Yes, sir.
common in all the cases. All the urethral operations fistula may occur. But main thing is that take up of the graft, because we have seen that whenever we give the skins, particularly figure, not the pedicle, the 100% skin is not taken. For that is I was asking
one thing I would like to
experience of taking the
here, I think he has mentioned that after removing of the catheter, it is very common to see that there is leakage from under surface of the pelvis. But we use the metal dilatation. We give them metal dilator, and after 2 to 3 weeks, they come up with no leakage. So this is a finding that we have found, because I think the fistula formation needs to be, the tract to be epithelialized. So if we can use metal dilator regularly every day in the postoperative period after removing of the catheter, then if the distal obstruction is not there, if the aperture is wide open, then the chance of epithelialization of the tract becomes less. So we use it regularly. After removal of the catheter, we give them dilator and every day they dilate. And after 2 to 3 weeks, the leakage is gone. One month.
No, one thing I tell you, and those who have worked in even I'm in PG hospital, it has been my routine practice to do the dilatation or calibration of the reconstructed new urethra. It was for almost immediately after taking out the catheter. I will do it almost every alternate days if needed, and all the cases that I will never allow the patient, I will never give the patient a dilator to do it by himself. I personally will do it if necessary for 1 month and 2-3 weeks. In fact, I have seen, I have seen before without doing this post-operative calibration by myself, and vis-a-vis doing the calibration by myself, I have avoided formation of the fistula. And the fistula, most of the cases of fistula formation is because of obstruction of the meatus. If you can keep the meatus open, then possibly there will be much less chance of fistula formation.
What is the option for using the flaps? I am not in favor of the flaps of it. because graph is not very much reliable.
Actually, I want to tell something, sir. Sir, it has been mentioned in recent literature that in hypospadias, beneath that sir, distal urethral plate, there is presence of extensive vascular sinuses. So, if you put the graft in that place, the
No, I am not in favor of graph. What is the
Okay, sir.
options of graph?
flaps, sir.
Options.
Sir, we can use sir Gatto's flap, sir, to cover the knee urethral plate.
Anything else?
Sir, we can use tunica vaginalis flap, sir, especially in bleeding cases of hypospadias.
What you have used in this case? That can be used also club. Reducer club?
Yes, sir. That is the reducer flap.
So our next presenter is Kompoj Kankide from IPGM.
Okay, just a minute. I have an announcement. Tomorrow we have a program. It is a non-aerobic program. It is financial planning for doctors. So I invite you all to come this program at 11:30 a.m. at Medical College main auditorium. And we have given the link in our groups. There is a Google link. So
Can I
please.
ask you one question?
Yes, sir.
This is the Bengal University meeting.
Yes, sir.
You cannot call any meeting at 11:30 because everybody is working. My question is that we'll discuss it.
Okay, sir. We shall discuss it. So we shall discuss it, sir. We'll discuss it. And next Thursday there is another program. There is a symposium on CA prostate in floor 10. It is on 7:30 p.m. next Thursday.
Good afternoon, respected teachers, seniors and my dear friends. Today I am going to present the case on urinary avulsion. Here is a female who is 36-year-old female presented to us with left leg pain. She was evaluated and found to have an 8 mm calculus in the upper ureter. And when we have planned for URSL, 9.8 volt CRS is used. And when it is introduced, it was introduced with little clot. And after that, it was decided to exchange it with a smaller size. When it was taken out, the scenario is like this is the CBE finding. Here we can see the whole of the ureter is avulsed. Then we have decided either to go for the immediate repair or the delayed repair. So we have proceeded with the delayed repair after 6 weeks, and we have put the patient on PCN. And after that, we can see here. This is the RGB finding after putting the PCN. We can see that in the upper ureter there is complete cut off and with a little extravasation of the contrast. Then the management options were discussed with the patient and their husband, including the ureteral reconstruction using the body flap, aerial ureteral substitution, renal water transplantation and nephrectomy as the last resort. And the patient was informed that the final decision has to be made in the operating room. This is the schematic diagram. Here we have after mobilization of the bladder is extended and we have measured the length, and it is found that the defect is around 18 centimeter. That we have decided for the extended body flap or the spiral flap, and this is the body flap that we have created, and we have taken we have covered all the defect, and this is the anastomosis. And in the outcome and the follow-up, the post-operative recovery was uneventful. The Foley's catheter was left in place for 40 days. Cystoscopy and the stent removal were performed after 2 months. Ultrasonography confirmed no hydronephrosis in the both kidneys 1 month later. Since then, the patient was followed up every 3 to 6 months by ultrasonography, urine test, and urine function test. She did not report any urinary tract infection. Neither hydronephrosis on both sides nor the renal function damage was documented during the 12-month follow-up period, and RGP was also done, which shows the free flow of dye in the bladder.
What will happen in outside educational institutions? Yes, SOAS which was there. SOAS region body flap was there.
I think you have,
first program and the voice reconstruction the same day.
No, sir.
Same day or later on.
Later on, sir. After 6 weeks, we have put the PCN, then after 6 weeks we have done the.
I think you have written that nephrectomy. Do you consider nephrectomy as an option?
Yes, sir. If it is not, no option is possible and the function is deteriorated.
You will chop off the kidney. I mean, is it an option in this case? I mean, in patient type?
Sir,
In this case, the nephrectomy may be not the option, sir. We can do anything can be used for that. At least auto transplantation can be done for this patient.
So why have you written electric? No, what are the other options? Other than this body plan?
We can go for so we can go for ileal transposition, or sir, young quantity we can done, sir. Even if it cannot be done, we can go for ureterostomy, or sir, we can also go for auto transplantation of the kidneys in the right liver.
Very rare option.
Yes. Last resort.
But nephrectomy is not an option.
তুমি ট্রান্সইউরেটরি ইউরেট্রোস্টোমি কি করে করবে? পুরো ইউরেটাস অ্যাবালশন হয়ে গেছে।
That remaining parts, upper ureter,
আপার পোর্শন ওখান থেকে গিয়ে নিয়ে যেতে পারবে এক সাইড থেকে রাইট সাইডে। আর 2 নম্বর আরেকটা জিনিস তুমি বলছিলে যে ওই এক জায়গায় একটা শব্দ ব্যবহার করেছিলে যে ইমিডিয়েট অপারেশন বাই দ্য ইমিডিয়েট রিসলিউশন ইউ অপটেড ফর ডিলেড রিকনস্ট্রাকশন। ইমিডিয়েট রিকনস্ট্রাকশন দিয়ে তুমি কি বলতে চাইছো?
Means at the same time, if we can counsel the patient, then we can, at the same time we can go for the repair as well.
Repair মানে
either voice plug or linear reconstruction.
Earlier substitution.
Earlier substitution.
What is immediate সেটাই ঠিক আছে।
One of our students had the same problem. During the operation, you try to with the removal of ureteric
Question.
just operatic stone. He tried to remove operatic stone. He put a guide wire. When he tried to introduce the ureteroscope, he could not find it. So he explored it, and he didn't find any ureter. So with the help of a general surgeon, he did a ideal substitution. Yes, or documented. And at that time, actually, he forgot to put a PCN. So there was a leakage, severe leakage. He called me. I told him to put a PCN. He put a PCN with the help of this ultrasonography, and gradually drain stopped. He did a CT scan. Under good excisions of the kidney, and he closed the drain. He removed the drain after complete healing. But actually, it is very critical. It's the same city. Two ideal substitute. It's very low.
What is your message from your case? What is your message? It is a very common situation.
Yes, sir. Whenever we are using the larger scopes, and if we feel any
using 8 to 9.8,
sir. If there is any, if we feel any
The age of miniaturization.
See, every time I go for this ureter endoscopy, in particular for ABBA ureter, using this region scope, every time I have got targets. And if the people, I mean, during the students, I mean, student life and university, used to do the work in PG hospital. I think some of you might remember, I used to tell about two stories. One story about this Abhimanyu. He knew how to go in, but he didn't know how to come out. So this is, I used to utter another word, one step forward, 2 steps back, Lenin's word. One step forward, 2 steps back means I just push ureteroscope inside and come out again. I just push it, come out again, just to see whether it is white, I mean, there is enough of space around. And I used to tell another story of a jacket. You see, the wise fox, the cunning fox, will never eat or take the chicken unless and until the hen, unless and until he is sure about the way to retreat. He will never attack the hens, or he will never take. And unless and until he is absolutely sure about the passage, way to retreat. So we must learn from all these things. If you are to use the very narrow scope. If it is there, better. If you do not have, go for stenting, wait, and then you can use these scopes of this size, 8 or 9 millimeter. So, and always must be careful, particularly regarding upper uretary. And I think many of us has got this experience. The most important thing is, treatment is, most important option is not to produce such situation.
Hello, Pankaj.
Yes.
What is your idea about multi-step in particular case?
So multi-step can be done, sir. We can take ileal segment around 15 cm away from the ileocecal junction. Around 2 segments, around 3 cm of segments can be taken, and in the anterocentric border we can cut, and then it is can be converted into a tube, sir.
It described earlier in BMG.
What is the ideal management of stone impacted in the upper ureter? After so many complications and USL, so what will be the ideal management?
We can use small scope and laser can be used under GA.
He said impacted.
Why the upper ureter is so much better now? Than the lower ureter?
Sir,
Why
because
people are afraid of this upper ureter?
For other words, where the avulsion actually occurs, normally,
upper ureter, sir.
not in the upper, it is the P junction.
U junction, yes.
Why the upper ureter is so much better?
Because of the sir, because upper ureter, it moves.
No, there are few, 3 or 4 causes.
Once the
Upper ureter is vulnerable than the lower ureter. What are the causes?
it is difficult to negotiate the scope also, sir, because of the
Whatever it may
peak
be,
and
sometimes ureteric orifice is also difficult to negotiate. That is not the point. What is the cause?
No physics.
Anatomically, upper ureter is thinner than the lower ureter. It is moving. It is not like there is very kinking. Always there is king because it is moving.
Yes.
The lower ureter is fixed and also curvature. When you are going up and up,
yes,
you are following the curvature.
correct.
And also changing. You are changing. Stone is going. You are changing.
Yes, yes.
So when you are changing, then there will be the traction in it.
Thank you, Congress, for
Which part is going on?
I have one small point. I remember an interesting anecdote by Oliver Traxler in one of his talks. He had said that when you see the ureter, if it looks rounded, then you know that will not accept a ureteroscope. But if it looks slit-like, especially when you put in the guide wire and it becomes nice and big slit-like, you know that it will accept the ureteroscope. So that is one way to know whether you should proceed or not proceed.
So next figure is
What is the Sukla? What is your idea? That it is impacted, rocks and impacted ureter. You go for endoscopic surgery at all. This lens, I suppose. What is
Depends upon the size of the stone and whether there is associated sepsis.
If they suppose this is, in some of these patients, you can find the same X-ray even after 2 years or 1 year, 3 years and silent, more or less silent. And there is a dilation happen. So those are the cases. If you go for ureteroscopy or removal laser or whatever you use, there is always the possibility of some of these concrete concave mix, some of these stone fragments, taking it and impacted making this wall. And ultimately ureter wall is absolutely unhealthy. And even if you remove the part of the maximum part of the stone, it will reform or it will form a state. So better to go for open surgery. Even if this is open surgery or laparoscopy, you can go for retrograde surgery. Give an incision, take out the stone.
But the size is not avoid a picture. Even open surgery will not avoid a
Of course, of course.
If there is all calcification,
Let's start.
there will be stem.
Good afternoon, sir. I am Dr. from RK Medical College, Kolkata. I am presenting a rare case on the isolated industrials. So my case, 15 years old boy presented with the abnormal location of meatal opening. There was no history of any urinary incontinence or lower urinary tract symptoms. No history of past catheterization or urinary retention. There was no history of past surgery. There is no history suggestive of any other anomalies. Family history was also not significant. And general examination was unremarkable. On abdominal cystic examination was within normal limit. And coming to local examination, single external urethral meatus located on the dorsal aspect of distal shaft of the penis was present. Cleft was present on the dorsal surface of penis. There was chordae present on the dorsal surface. Size of the penis was small, that looked like buried penis. The scrotum testis rectal examination was unremarkable. Coming to blood investigation was normal. Urine routine microscopy normal. Ultrasound pulled down was no abnormality detected. X-ray pelvis, there was no any bony abnormality. So we did here the modified tendril branch repair of the fastidias. First we did the 2 parallel incision we have taken on the side of the urethra and coming up, encroaching up to the corona on the ventral aspect, and we degloved the penile skin up to the base of the penis. Then we did the separation of both the corpora cavernosa and the espongiosum, and we looped with the infant feeding tube. So after that we did the urethral tubular erection. with the Vicryl 40 in the running suture. So after that we did the corporal body approximation on the dorsal aspect of the corpora cavernosa. So after that this moved the urethra ventrally. So after that we did the glans reconstruction in the double layer. First is the subruticular layer and then the surface layer with the Vicryl 40 suture. So then after that we did the two fixation on the penoscrotal junction and one in the penopubic junction to gain the penile length, and then the penile skin approximation to the coronal circle first. We did the hatchet flat technique to give the releasing incision on the lower aspect of the pubis. So we have done this further. On the post-operative day 5, we have this picture. Slight edema was present. The suture line was healthy and patient did not have any complaint. In the follow-up, we removed the catheter after about 3 weeks, and this picture is about 1.5 months. Thus, wound is healthy and meatus is centrally located. So this is the video. The patient is voiding satisfactorily with the normal voiding patterns. Coming to the discussion, the modified cantilever technique represents the attachment of distal urethral plate to the glans about 0.5 to 1 centimeter. So urethra, there is a literature on the male ibis is very scarce. So this is very rare entity. So we presented this case. The main factor contributing to this incontinence include the distorted anatomy of bladder neck and posterior urethra, along with the histological abnormality in the roof tissues. Adolescents with isolated epispedias may suffer from the psychosocial and sexual issues. So we should be very cautious about the consultation should be taken from the psychiatry and urology or endology during the transition of care into the adulthood for comorbid condition to be addressed properly. So my take-home message is that most cases of the epispedias are associated with the other congenital anatomic anomalies, of which the bladder atrophy is the most common. Finding of the isolated epispedias without associated anomalies is very rare. So surgical repair should be attempted in case of extrophy or bladder as soon as possible to avoid the osteotomy. Modified cantilever translate technique provides the most natural appearance of the glands and potentially better cosmetic outcomes. Thank you.
What is the most important structure that you must try to protect?
It's a neurovascular bundle that is located on the lateral aspect in case of the epispedias.
Regular dissecting must be very careful.
Yes, sir.
You isolated the body.
Sir, we did not isolate it, but we have taken the bite on the dorsal aspect of the penis, taking care that the neurovascular bundle
Along with the cross. Along with the
No, sir.
These are the neurovascular bundles along with the what you did? How did you preserve the neurovascular bundles?
Sir, we assume that the bundles are situated on the lateral aspect of this penis.
There is no question of assumption. We did not identify the neurovascular bundles.
So separately we did not identify it.
So when you are operating, this is the primary thing that Sarah was asking.
You should, the most important structure.
So
You must
try to
identify.
prevent the damage to those.
Yes.
Otherwise, erection will be lost.
Because you are totally separating this both the flora and the corpus convolution together. And because in the epispedias you see what happens, everything is rotated laterally.
Whenever you operate
The
with the
neurovascular bundle which was supposed to be the dorsal aspect becomes lateral.
Thank you.
Next presenter is Dr. Pantupati Mukherjee from Maharashtra.
Good afternoon, respected chairperson, respected seniors, teachers, and dear colleagues. So I am presenting our initial experience of double face augmented urethroplasty in near obliterative penile urethral stricture. So this gentleman Enzo Palminteri first described double face urethroplasty in 2008. He is from Italy. He proposed double face urethroplasty for bulbar urethral stricture, which near obliterative is very narrow, which is defined as urethral plate less than 6 mm. The double face may be dorsal inlay plus ventral onlay or ventral inlay plus dorsal onlay. Now recently we did all our bulbar urethral stricture, which is mostly narrow with skirt and fibrous urethral plate with dorsal inlay with ventral onlay. Now from this experience, we tried our encouraging measures to extend into the realm of penile urethra. We had total 5 cases, 3 cases of BXO with penile urethral stricture, 1 case of inflammatory long penile urethral stricture, and 1 case of very hypospadias repair. So this is the representative case. The gentleman presented with voiding difficulties, voiding symptoms, recurrent UTI with a pinhole meatus. The RGU and MCU is done, showing a long penile urethral stricture with preservation of the bulbar urethra. This is the obstructive uroflow with Qmax only 2 ml per second. Now we have to, this is our routine practice to do ureteroscopy before any intervention. Here we had to do dorsal amiotomy to introduce the ureteroscope. So this is the finding, which is showing almost obliterated penile urethra with abnormal skirt mucosa. Then we through a circumcising incision we declub the penis to expose the whole of the abnormal urethra up to the penobulbar junction. Then we did a ventral urethrotomy to expose the skirt dorsal urethral plate, which is incised at the midline up to the tubica albuginea of the corporal bodies. Then we put a buccal mucosa over the dorsal as the dorsal inlay. The width of the urethral plate after dorsal inlay is becoming around 16 mm from mere 6 mm. Then we put a ventral onlay over that area. But to prevent anastomotic ring, actually these onlay flaps, whether inlay or onlay, becomes a tube after some times. So prevent the anastomotic ring, we put the dorsal inlay incision is lesser than the ventral urethrotomy, so that ultimately the tube becomes an oblique anastomosis in the proximal and distal part. So this is the width of the ventral onlay. Then we covered this ventral onlay for vascularity, a robust right tunica vaginalis. This is the skin closure. And the post-op at 3 months, we did a clinical examination, history taking, and a uroplometry. The uroplometry is showing good unobstructed voiding. Then we actually applied these principles to a failed hypospadias repair. It was actually a penoscrotal hypospadias which was managed by a long tubularized incised plate using a right tunica vaginalis. But unfortunately the whole repair broke down, and the child, young adult actually presented with a proximal penoscrotal fistula with complete breakage of the repair on the distal side. So we did the same thing. We incised the remaining urethral plate, put a buccal mucosal dorsal inlay followed by a ventral onlay, which is covered by left tunica vaginalis, as the right side was already used. So these results are encouraging. Only one patient with DXO developed a neonatal stenosis, which needed deviation myeloplasty. All patients presented with good urine flow with no significant PVR and no instrumentation needed for voiding. So it's a technically not very demanding surgery which can be applied with the urethral plate with is less than 6 mm. There is severe spongiofibrosis. It's technically simple. No mobilization of already scarred and less vascular urethral plate. There is no attempt to tubularize, And ventral urethrotomy should be more than the dorsal inlay length to prevent anastomotic ring. And it's also effective in redo cases. Thank you.
I think you have proposed an excellent idea. Thank you. I wanted to ask you, in your first case, how many buccal grafts did you require?
Two sets from each buccal mucus.
I also want to ask Udaida and Kapanda who have used tunica vaginalis clefts for a long period. What if you do not use buccal mucosa and only use tunica vaginalis cleft?
Because in what is the follow-up period?
So follow-up is only 3 months. Recently we
Because we have more than 2 years, so I think 60 to 70% BFO has been restructured. So we have now at NS Medical College, we have now abandoned the buccal mucosa. We are not even the mucosal skin or venous skin, everything. We are seeing what the result with the earlier buccal mucosa.
classical textbook teaching is you should not use penile scan, especially in PX.
So you are going against the classical teaching, what I have learned in our book. I am not going beyond that. So what's the result? Because we are seeing BXO, we have done a lot of cases, and it is after 2 years maximum. So only few cases was to 5 or 10 years. Maximum cases was came for OPD restructured with very even the 5 to 6 months dilator could not pass. We are using the tunica regularly, that is a vascular file, but I am not using the BSO now at present. For last 3 or 4 years we are not using BSO for the buccal mucosa. And this is our result.
So you are putting only tunica vaginalis cleft?
We are placing the mucosal skin if it is available, or some the dorsal, we are giving the penile skin, not we are giving any buccal mucosa.
Flap, you are using a flap.
Not flat. We are putting the graft. Yes. Three graft.
So you are using penile skin graft dorsally
Dorsally.
and tunica vaginalis cleft?
Mentally. And even in these cases, we have preferred to, for your past case, we prefer the DNA or the plastina.
Okay.
Only the layout and covering with. That is also the given the good result. More than 2 years, it is quite okay. Now we have to go for what it result at 5 years or 10 years.
Okay. Thank you, sir.
Can you explain in DNA you leave it open?
Yes.
And how long you leave
It can give to the up to the prosthetic, even if the just below the vulvar urethra. It can be I use the up to the vulvar urethra yourself.
Only one piece.
During my stay in NRS under Mandal sir, so we have used the DNA rotoplasty, long segment stricture, where we have opened, we have developed the penis, opened it ventrally, and we also sometimes we make a
That was this perineum.
sorry, that was perineum. So we have placed a buccal mucosa at that time. We have placed a buccal mucosa in the dorsal aspect and put a long tunica vaginalis bag ventrally and kept the catheter for 6 weeks. And
Like what he has done.
he has not done small segment stricture. It is for long segment stricture. I'm saying long segment. So at that time result was like their success of 50%. Then Udaida has revised the procedure. Then what he have done that he have kept a neometas at perineum. So
Delivered fistula.
delivered fistula perineum. So after that result become I think better.
Recently, I have also done a case at National Medical College. So many will say that what's the result? Though it is 3 or 4 months.
Now the patient is on catheter.
Yes, the patient came to my center. I asked him because I asked the Sasman to send the patient how is he is behaving. We have put now it is 22 French is catheter case. Usually it is accurate 22 French catheter. And surprisingly enough, we have made a fistula at the perineum. The patient is voiding parenthally. That does not need a clear. In few cases, this fistula, bottom fistula does not need any clear closing because the patient is passing urine through the normal meters. Stops automatically. So we have planned for closer, but ultimately the patient does not want to clear because his body is quite good and
There there is a opening somewhere along the length of the urethra, there will be dropping.
There is some voting is there, but patient is voting. We always plan for closer, but patient does not want closer because after seeing the so devastating complication like that, it does not want the closer. Yes, I am doing well.
Next, bioplasty in the case of
Good afternoon, my teachers and my colleagues. My case is a laparoscopic vertical flap pyeloplasty for failed endoperitoneum. So, a 33-year gentleman attended our OPD with complaints of recurrent left flank pain and fever. He had history of left RIRS 2 years back for a large impacted upper urinary calculus. Later, he developed upper urinary stricture at impaction site, for which laser endoperitomy was done 1 year back. DJ stenting and replacement was done a couple of times. At that time, he was not willing for a pyeloplasty. The patient developed hypertension for last 1 year, which is controlled on medication. Investigations are unremarkable in the blood investigations. The CT scan showed left-sided moderate hydronephrosis with a narrowing just distal to PUJ. It was a short segment narrowing and a small secondary calculus about 4 mm in the lower calyx. So we planned for a operative procedure. So this is the schematic diagram of the port position. We opted for a standard laparoscopic procedure in the left lateral position. This is a video. So after mobilization of the colon, we exposed the kidney and the PUJ. There was a little bit adhesion at the PUJ, so with a sharp and blunt dissection, we exposed it. We also, to gain some length, we also did some dissection in the posterior and superior part, so the kidney is mobilized, so we can get some length. After that, the measurement of the flap was done. So the incision was planned, and there is for retraction we put a stitch to retract the gerota flap, and an incision was made. So the incision, now this incision of the PUJ made, and it carried along the lower part up to the healthy ureter, and in the upper part we created the flap. Here the stone accidentally fell and we removed it. Otherwise we could use a flexible ureteroscope and remove the stone. Now this a flap is being created. In laparoscopy it is difficult for the access to create the incisions, so the port placement is very important. Here we also encountered some bleeding, but not to cauterize too much further bleeding, so that to preserve the vascularity. After that, this flap is gently created. Cut it up to a good healthy base. Also we measured the apex, which goes to the ureteric, the content of the ureter. Now the flap is rotated and the apex is stitched with the most distal part of the content of the ureter. Now we used 4-0 vicryl in a continuous fashion. Also we can use interrupted sutures. So now the posterior part is sutured of the flap. The posterior suture line put the DJ stent. We can use the hollow suction tube or any laparoscopic hollow instrument to put the DJ stent. Now the DJ stent is being placed and we will plan to close the anterior layer of the ureter and the pelvis. The renal vein, we can show the lower part of the renal vein also. Now what we did, we just give a suture, one single suture at the apex so that it doesn't retract, or we can use it in a watertight fashion, and we started from below and with a continuous suture we just close the anterior layer of the ureter. Last we sutured with the previous suture. And diagnosis is being completed. Some blood and the urine which were in the peritoneal cavity sucked out and the tube drain placed. The patient recovered well. We removed catheter on the POD3 and we removed drain on the next day POD4, and the patient was discharged on the same day. Thank you. Actually the patient was operated recently, so we could not have a follow-up.
So what is your opinion? After how many days we will do follow-up IVU?
So we will do follow-up IVU after 6 weeks.
When you will do the 6 weeks?
At the time of removing the stent, we will do a follow-up IVU.
Not after 6 weeks. After how many days we will do PTS scan? That you should know.
Yes, sir.
How many you will do IVU?
We will do RGP at the time of removing the stent. And we can. So after 1 month of removing stent, we will do a follow-up IVU.
Usually 6 months.
In this case, you had a big renal pelvis to take up slab. Suppose this was a small intrarenal pelvis and a huge dilated kidney. What would be your option?
We can go for dismember pyeloplasty, as it was a small stricture, short segment. We can go for a dismember. Okay, so we can go for Foley's YP plasty.
What else?
Remember that the pelvis, I have said, is intrarenal, means it is a small pelvis. You cannot use the renal pelvis. So what can you do for?
So we can go for in vitro calicostopy in this case. So if we don't have a
small stricture.
yes,
Small stricture, intrarenal pelvis, very small pelvis. So what are the other options?
Previously, when there was no actually this PCNL, URS, etc. During this lithotomy, they easily injure the ureter office. There is a technique which was take the capsule there, capsule of the kidney, and with the capsule we cover the ureter. With the capsule, you repair the thin stem of the ureter. With the overhead, we used to over a infant feeding tube. At that time there was no digestion. You can use an capsule of the kidney.
Sir, capsule किलो में कितने की
कैप्सूल के किडनी ना ऐसा कोई कैप्सूल के किडनी जस्ट वीडियो बनाने ऊपर में आज तो कैप्सूल ये सब
Do you routinely do the dismembered or the vertical flap IVU?
routinely it is done dismember.
Why have you done the
Flap pyeloplasty in this case?
Sir, in this case, the patient was previously done, endopylotomy was done. First of it was a stricture case, post-operative stricture. Endopylotomy was done. There was a little bit adhesion, so we suspected loss of vascularity in this case. So we, to preserve vascularity, we proceeded for flap pyeloplasty.
Now in our center we are doing the flap pyeloplasty routinely, we are not dismembered any PUJ obstruction. Even our PGT or any, all are doing the vertical flap pyeloplasty by laparoscopy and open surgery. The result is good. Even the time, it is the operation time is I think quite less than the dismembered one thing, and it is the result is also good. Time is less. I through Gopal will tell the laparoscopic dismembered and the laparoscopic vertical pyeloplasty, what is the time difference?
Time taken is the same. Actually, I read somewhere that if you are in doubt about the etiology of the PUJ, do a flap pyeloplasty.
There is something else.
And if in any case no, if there is not segment PUJ, we are doing a flap pyeloplasty.
But it's a huge dunnate pelvis. In that case, the longitudinal cardiac cell.
No, even with the reduction at the same time. Reduction can be done.
So if there is vessel, how can one more the vessel, sir?
Only in that case, if there is any vessel, the crossing vessel, then you have to dismember. Otherwise,
Sir, if there is any eperistaltic segment in that, is it okay to do a vertical?
whatever, it is only the length of the stricture that varies. Very long, if there is a long of the stricture, long you can make a more flap. Because I have heard one word from our teacher, Dr. Anandasu. If one is dismembered, then it is always dismembered for the time. That's why the vertical flap is now we are doing for the much and more because it is not popularized. So
I think the question is if there is a dynamic segment, you are not exciting that.
no, nothing will happen. If the vertical flap, the pelvis is coming to that portion of the short segment of the episode does not hamper. Then the patient will go on.
So the classical teaching in the examination, you have to tell the number one.
Yes, sir.
Number two, if there is very short, very narrow segment, you cannot do flap arming. Because you cannot get a restriction. Number three, if there is crossing vessel, you cannot. Number four, if the pelvis is very small, you cannot. So flap arming only you can do in those cases where these are not present. Then you have option. You can do flap arming or you have can do the dismembered palpoplasty. But in examination, better to do first the dismembered palpoplasty. If the examiner asks for question, yes, there is also option continuation very important. But there are definite situations where you have to do flap palpoplasty. When this picture is very long, you cannot do like this. You cannot do dismemberment.
So thank you all. We are closing the session.